Hello, psychology folks. Hopefully, everybody has had a good weekend and is looking forward to a good Thanksgiving week. Um, we'll be on schedule with our video lectures for this week, and also we'll have one next weekend that should give us all the information that you need to know to do an excellent job on exam number 4. So let's jump right into psychological disorders, and to do so, we'll replay, for those that might not have seen it, our lovely favorite video from Young Frankenstein. So a couple things to think about from that video. One, always hold on to your brain because dropping it can be bad. But two, is there actually such a thing as an abnormal brain? And what what does abnormal mean when it comes to psychology anyway? Um, how and why do we classify some people as abnormal, or for actually what is abnormal behavior? According to the American Psychiatric Association, abnormal behavior is defined as, or to say it more accurately, abnormal behavior is defined in medical terms, because remember, a psychiatrist is a medical doctor versus a psychologist who does not have a medical degree. So the American Psychiatric Association defines abnormal behavior as a mental illness that affects or is manifested in a person's brain and can affect the way the individual thinks, behaves, and interacts with others. Abnormal behavior may also be defined by 3 criteria that distinguish it from normal behavior. And those 3 criteria are these. Abnormal behavior is deviant, in other words, it deviates from the norm, is maladaptive, or personally distrustful over a relatively long period of time. Long period of time is significant there. Now, only one of these criteria need to be present for behavior to be labeled abnormal, but typically 2 or all 3 are present. So, abnormal behavior being deviant. Abnormal behavior would be considered atypical or statistically unusual. In other words, it's different than what you would typically see in society. Often individuals are atypical in their behavior, though we don't necessarily consider them abnormal just because they're different. But we do consider atypical behavior abnormal when it deviates from what is acceptable in a culture. And so, right there, you have an interesting definition of abnormal, because it's culturally connected, which means what's abnormal in one culture might not be considered abnormal in another. I noted that OCD, obsessive compulsive disorder, things that individuals might do obsessively or repeatedly may be unusual or atypical in a particular culture, which could lead to a definition of the behavior being abnormal. Abnormal behavior being maladaptive. What does maladaptive mean? Maladaptive behavior is behavior that interferes with your ability to function effectively in the world. So, example, somebody who believes he can endanger others through his breathing may go to great lengths to isolate himself from people he believes for their own good. Um, and he believes that his belief negatively affects his everyday function. So let's say somebody has imagines that they have some uh, bizarre contagious disease, and if they go out in public, they're going to destroy the world, and so they hide themselves away. That behavior would be considered maladaptive because it affects your everyday functioning. Um, Behavior that is a danger to the person or to the people around that person is also considered maladaptive because it has the potential to harm, and so that also goes into the definition of abnormal. And then the third category, abnormal behavior is personally distressful over a long period of time, meaning the person engaging in the behavior themselves find it troubling. So it may be behavior that doesn't affect the relationship with anybody else, nobody else knows about, but it bothers the person who's engaging that behavior. An example, a woman who secretly makes, or a man, who secretly makes themselves vomit after every meal, a sign of bulimia, which we'll talk about, may not be seen as deviant as far as others around them, but the pattern itself may cause him or her to feel guilt, shame, and despair. And so that personally distressful definition would lead that to be considered abnormal behavior. Now, as I mentioned, only one of these needs to be present for behavior to be considered abnormal. Though typically you're going to find that two or even all three are going to be present. Uh, and this is what makes abnormal behavior sort of interesting and difficult to define, because culture and context can affect the meaning of what's supposedly abnormal behavior. Culture establishes the norms through which our behavior is evaluated, and cultural norms can be mistaken. It used to be that cultural norms were that cigarette smoking was not a problem. People in television shows chain smoked cigarettes. The shows were supported by cigarette advertising, and the cultural norm was this wasn't any problem. It doesn't affect anybody negatively, and then of course, we find later that cigarette smoking is devastating physically, and now it is no longer the cultural norm that smoking is okay. So cultural norms change. Cultural norms can be oppressive and prejudicial. You think about what was considered abnormal and deviant 50, 60, 70 years ago. Would that be considered the same today? And what was driving that? Cultural norms obviously can vary from culture to culture, and cultural variation makes it difficult to compare psychological disorders across cultures. And again, the problem here is this isn't something that you can just give somebody a blood test for and determine whether or not their behavior is normal or abnormal. There's a lot of subjective judgments being made here. And as in some of the other things that we've talked about in this class, there are different theoretical approaches to psychological disorders. Just as there are different theoretical approaches to psychology itself, different theoretical approaches to personality, there are also different theoretical approaches to psychological disorders that to some extent mirror those other approaches. So, for example, when it comes to psychological disorders, we have the biological approach. The biological approach attributes psychological disorders to organic internal causes. Now, this approach primarily focuses on the brain, the actual physical structures of the brain, whether it's working right or not, genetic factors, what was passed down to you in your genes from your parents, the functioning of neurotransmitters, whether you have, for example, enough dopamine or not enough dopamine, and whether that needs to be managed. And the biological approach is very evident in the medical model of psychological disorders, which describes disorders as medical diseases that have a biological origin. So from this perspective, this is where the term mental illness comes from, because the biological approach views a mental disorder as a sickness. There's something wrong with the structure or the functioning of your brain and your brain chemicals, and that's why mental illness patients are called patients and why they're treated by doctors. And so that is the mental illness approach, which is very much tied to the biological approach. In contrast to the biological approach, the psychological approach to disorders emphasizes the contributions of experiences, thoughts, emotions, and personality characteristics in explaining psychological disorders. Psychologists might focus, for example, on the influence of childhood experiences that we've talked about, the psychodynamic model, personality traits, learning experiences, or cognitions or beliefs in the development and course of the psychological disorder. The sociocultural approach to psychological disorders, as you would imagine, emphasizes the social context in which a person lives, and that would include gender, ethnicity, socioeconomic status, family relationships, and culture. The sociocultural perspective is focused on the way that culture influences the understanding and treatment of psychological disorders. And the frequency and intensity of the disorders vary and depend on what the social, economic, technological, and religious aspects are of those cultures. As you can imagine, the sociocultural approach is varied because what may be considered a psychological disorder in one culture might not in another. Dealing with psychological disorders is not particularly an exact science, and really still developing and understanding what we know and what we don't know. And then the biophysical model is a model that says abnormal behavior can be influenced by biological factors like your genetic makeup and psychological factors. Actually, I should have said that's the biopsychosocial model, biopsychosocial, three in one word there. So it's influenced by biological, psychological, and sociocultural factors such as gender, and that the factors can operate alone and can also be combined with one another. And this is sort of reminds me of the eclectic approach to psychology, which says that psychological disorders can have many different contributing factors, and that seems to make a lot of good sense to me anyway. So how do we classify abnormal behavior? If we're psychologists and we're going to treat behavior and describe it, how do we classify it? Well, if you're familiar with the classification system from biology, you know that it works similar to this. Here are the 5 kingdom classifications of organisms. So you have your living organisms, and under which you have viruses and bacteria, and then you have plant ancestors, fungi, plants, and then animals. And so you can see you categorize the different types of organisms based on the characteristics of those organisms. In this case, the fungi, the food is digested outside of the body. The plants, they're non-motile, meaning they don't move. The animals, food is ingested, taken into the body. You categorize the living organisms based on the characteristics of those organisms. And something similar is done when it comes to psychology. You may or may not be familiar with the Diagnostic and Statistical Manual of Mental Disorders, also known as DSM, and that's the psychologist's Bible. This is and it's a really big, thick book. This is the book that psychologists use to diagnose whether or not you can be classified as having a psychological disorder. This book has the criteria, essentially sometimes it's actually a checklist of, do you have this and this and this and this, and by using the Diagnostic and Statistical Manual, psychologists can officially diagnose you or as having or not having a particular type of abnormal behavior. And so here would be an example, similar to the the organism categorization. Here's an example of classifying abnormal behavior. And you've got the developmental perspective, emotional, behavioral, spiritual, under here, gender identity, autism, personality disorders, schizophrenia, eating disorders, and this is just a general a block list or the word for some strange reason escapes me. A pattern, a structure. What word am I looking for? I think we're having memory issues here. Chart. The word is chart. This is a chart indicating psychological disorders, and here you see they range from being healthy, the healthy perspective, to having minor psychological issues, to major and chronic psychological issues. And in this way, psychological disorders are identified and diagnosed. And here it is an example. This is from the DSM-4 book. Now, if you note, the DSM-5 is what we saw here. DSM-5 is a new manual that was just recently approved, but this is an example from DSM-4. So this is the criteria for diagnosing atypical depression. And so mood under atypical depression, mood reactivity, meaning that mood brightens in response to actual potential positive events. So you have mood reactivity, you can brighten when you have this atypical depression. And then to be diagnosed with atypical depression, you also have to have, two or more of the following. Either significant weight gain or increase in appetite, hypersomnia, which I believe would mean sleeping a lot, leaden paralysis, a heavy leaden feeling in the arms or legs, a long-standing pattern of interpersonal rejection sensitivity, and so you would have to, as the psychologist is talking to you about what you're dealing with, he would be, I guess, having a mental checklist and determine whether you had two or more of these. And then the criteria are not met with melancholic features or catatonic features, and so you don't have melancholia or catatonia. You're not catatonic. You're not just completely unreactive. And so if in fact your mood brightens in response to events, you have two or more of these, and you don't have these features, then the psychologist can officially diagnose you with atypical depression. So that's, in a sense, how it goes, and it's a little weird, frankly. But when you think about it, at some point, when you categorize psychiatric disorders or mental disorders, you've got to have some standard by which to judge. And one reason why you have to have that is, at some point, somebody's insurance is going to likely be asked to pay for treatment for a disorder, and the insurance company is going to want some sort of way to confirm whether or not the person actually has the disorder they're paying for treatment. And so that's one way. Also one reason. Other reasons would be, how do you determine what you're treating? How do you connect treatments to different categories of disorders? How do you measure to see if the treatments are actually effective? All this requires the ability to classify abnormal behavior. Here's the classification of Asperger's disorder from the Diagnostic and Statistical Manual, and it talks about you've got impairment in social interaction in at least two of the following, talking about eye contact, not being able to develop peer relationships, not being able to share enjoyment, a lack of emotional reciprocity, and then you would have to have restricted and repetitive patterns of behavior in at least one of the following. So again, and then this disturbance causes impairment of social and other important areas of function, and then also that there's no clinically significant general delay in language, and no clinically significant delay in cognitive development, because this would indicate that it's something other than Asperger's that you're dealing with, and that the criteria is not met for another developmental disorder. So again, this is when a psychologist is diagnosing whether or not somebody has Asperger's. This is the checklist that they're going to go through based on their interaction. We mentioned that we have a new diagnostic and statistical manual. Just for reference, here you have there's the DSM-3, DSM-3R for revised, DSM-4, DSM-4 which has been revised, and now we have DSM-5. So as psychologists' understanding of psychological disorders has evolved, so has the definition, and some things have been removed as disorders, some things have been added, and as things are removed and added, the diagnostic and statistical manual has been updated, and we're up to 5. And note we've also dropped the Roman numeral. So in this graphic you can see the difference between the change in DSM-4 to the DSM-5. And so in DSM-4 we had autistic disorder. DSM-5 changed that to autism spectrum disorder, and in DSM-4 the number of criteria required to diagnose autistic disorder was 12. In the new DSM-5 it is 7. The minimum required for a diagnosis was 6. In DSM-5 that's down to 5, and the number of domains was changed from 3 to 2. And so here you can see, for example, in the social interaction domain for autism spectrum disorder, in this case at least 2 of the 4 were required. In the new criteria, all 3. So in some ways the minimum requirement is less than the minimum requirement for the new diagnosis. And again, it's just to give you a sense of how things are evolving regarding autism spectrum disorder. And in this case, the minimum required of repetitive behaviors is at least 1. In this case, at least 2. And so, while they may be lowering the number of criteria and the minimum of diagnosis in some of these specific diagnoses, you can see it's a little bit more difficult. Here is just to give you some additional perspective, some explanation of how those changes are occurring.
I'm on the steering committee for the U.S. Psych Congress, and I'm here today with Dr. Tim Willens from Harvard. Thank you for joining me. So you're giving a great talk about ADHD today. Talk to us a little bit about what DSM-5 means for changing diagnostic criteria for ADHD.
Well, it's really interesting. The DSM-5 is actually really going to affect adult ADHD more than child ADHD. So a few things that it's going to do that really I think is going to make it a little easier to make the diagnosis of ADHD, or the full diagnosis, I should say, as opposed to one of these qualified diagnoses of ADHD not otherwise specified. A few things notable. First, the symptoms are essentially the same as the DSM-4, so people don't have to relearn the symptoms. What's going to change is that if you're 17 years of age or older, you don't need 6 of 9 inattentive symptoms or 6 of 9 hyperactive impulsive. You only need 5 of 9. So they're relaxing it by 1 symptom. Number 2, the age of onset. It used to be you had to have the age of onset of some symptoms before the age of 7, and that's now been moved to age 12. Now, why that's important is many adults have difficulty remembering, back to first or second grade. And then the last issue that's important in terms of adult ADHD is that the impairment doesn't have to be an absolute impairment of functionality, that you're not doing well absolutely, but it's functional in terms of a relative impairment. And what that means is you're not doing as well as you could have done.
Yeah, if you didn't have those symptoms.
Exactly. And then the one comment I make for child ADHD is that now for child ADHD, you can have Asperger's or what's now autistic spectrum disorders and have ADHD. They're not mutually exclusive. You can have both disorders.
And these are sort of based on research findings over the last 10 years?
These are based on research findings, and I think that they're a real positive move forward to help make more accurate diagnosis and help to the adult practitioner make the diagnosis of adult ADHD.
Okay. Thank you, Dr. Willens. Fascinating. Glad you're at Congress. Thank you.
Yeah, I may have said that was that video was about autism. It actually talked about autism spectrum disorder and ADHD. And we think, well, what's the big deal about evolving or changing the diagnosis of autism or ADHD? And it can be significant when you think about it. If the DSM makes changes that suddenly more types of behavior are now diagnosed as ADHD or autism, then you're going to have more people with that diagnosis, more people that potentially will now be eligible for insurance coverage. So you may have more people being prescribed medications for ADHD. Obviously, the expense goes up, and more people are now being medicated. As a result of the expansion of that criteria. On the other hand, if you contract or shrink the criteria for, say, something called some types of autism, suddenly now you have people who previously had been diagnosed as autistic and maybe had been receiving some government-funded training, benefits, education. Well, now that goes away. So the implications for changing the criteria can be significant. Here's a look at some of the other changes that have occurred between DSM-4 and DSM-5. Major depressive disorder, that's changed. In the past, people experiencing grief from the loss of a loved one have not been considered to be depressed, just temporarily grieving. That's changed, and now grief due to the loss of a loved one is included in the definition of depression. So if you're grieving from the loss of a loved one, you could be labeled as depressed. Could that be significant? If suddenly that goes into your medical record, could that potentially affect how you're treated at work, your insurability, a lot of things. Again, we talked about ADHD. Some of the requirements have been loosened, so an overdiagnosis is a concern. Asperger's syndrome. There is apparently now no such thing as Asperger's syndrome in the DSM-5. That has been dropped. Those previously diagnosed with Asperger's may not be diagnosed with anything at all and may not receive any kind of treatment. PTSD, previously a person was thought to have had PTSD who witnessed or experienced a trauma. Now PTSD can be diagnosed in somebody who only hears about a trauma. So basically, when you see something or hear about something on the news, you can now potentially, according to the new diagnosis, have PTSD. Could lead to a huge increase in diagnoses of PTSD. Disruptive mood regulation disorder, a new diagnosis for children who have wild mood swings. There's concern that this diagnosis is basically you're creating a diagnosis for children who just have bad behavior, and now suddenly they'll be treated as if they have as having a psychological disorder. Mild neurocognitive impairment is a new diagnosis for adults experiencing cognitive decline, which makes me wonder if I now have that based on my trouble remembering things in this video. And of course the thing is, lots of adults experience mild cognitive decline. Some people will argue that's just part of aging, and now you're saying that a normal part of aging is actually a mental disorder. So there's concern that you're adding and what they call pathologizing what's a normal part of aging. So those are a lot of the concerns in these changes. Here in this video, the president of the APA addresses concerns such as this.
The DSM-5 was created in order to assist clinicians in being able to better recognize mental disorders in patients and establish a diagnosis and then provide them with treatment. So to the extent that DSM-5 is an improvement over its predecessor and reflects the current state of our scientific knowledge, then it will help doctors provide better care, and will improve the quality of life and the health of patients. And that's really the main goal. The DSM, in all its iterations, and particularly in this iteration, DSM-5, it doesn't jump ahead of where scientific research is. It's at the cusp, or it lags just behind to be conservative and not overstate evidence that has not been firmly established. It reflects the state of our science, but doesn't tell you where science is going to go in the future. We would have loved to have science brought us to the point where we know that this gene or this toxin or this trauma produces this disorder, and you can make the diagnosis by this blood test or this kind of x-ray or this type of electroencephalographic procedure. And God willing, that day will be coming fairly soon. The criticism that frequently occurs, undeservedly, is that the proliferation of diagnosis tries to pathologize normal behavior. And I simply cannot agree with that. I think it's just plain wrong. I say it's wrong because if you look at the history of diagnoses in all areas of medicine, and let's take ICD, which is really the coda of diagnoses for medicine. If you look at the evolution of ICD, which is now in its 10th version, its 10th iteration, it's increased by about 8% in number of diagnoses with each new edition. It's the nature of science. We're identifying disease where it previously wasn't recognized, or we're able to subdivide disorders into more precisely defined disorders when they were grouped together before. So why should mental illness be any different in terms of expanding where we understand and can recognize and diagnose better and provide treatment to people? And that's what's happened. The reality, though, is that DSM-5 does not have any more diagnoses than DSM-4. It has not expanded the pie. What it may have done is sort of slice the pie in slightly different slices to more precisely reflect the conditions people suffer from based on the intervening research that's been done since the last edition. But it isn't including more people who previously were not considered ill. It's simply defining them in different ways.
All right, so that being out of the way, we're going to spend the rest of this class talking about, I guess, the more commonly recognized psychological disorders. I'm going to burn through this pretty fast, so if you need to go back and take another look at some of this material, feel free to pause the video and do that. But we're going to talk about 6 categories: anxiety disorders, mood disorders, eating disorders, dissociative disorders, schizophrenia, and personality disorders. So, anxiety disorders. Anxiety disorders include generalized anxiety disorder, panic disorder, specific phobias or fears, social anxiety disorder, obsessive compulsive disorder you may be familiar with, and then post-traumatic stress disorder, also known as PTSD. Generalized anxiety disorder is not just the fact that you have everyday feelings that you might be anxious or nervous. This is persistent anxiety that goes on for at least 6 months, and you have no idea why. It's anxiety for no reason. That's a generalized anxiety disorder. Panic disorder, and much like everyone else, you might sometimes have an experience that sends you into a panic. Maybe you suddenly wake up and realize you're late for class, or that you forgot to do a paper. In a panic disorder, however, panic disorder is recurrent, sudden onsets of intense terror, no warning, no specific cause. There's nothing to cause your panic. It just happens. I mean, these people sometimes feel like they are having a heart attack or are going to die. Also, classical conditioning has shown to play a role in panic disorder, because in panic disorder, let's say when you have a panic attack, your heart rate speeds up as a result of the panic attack. People who deal with this can actually be conditioned to where they associate rapid heartbeat with the panic attack, and so anything that causes their heartbeat to move faster even physical exertion, their body, their brain in this classical conditioning situation attributes the increased heart rate to a panic attack is coming, and they'll actually have a panic attack because of that. So, interesting situation there. Women twice as likely as men to have panic attacks. Possible reasons: biological differences in hormones and neurotransmitters. And it may also be because women cope differently with anxiety provoking situations. That may well be a sociocultural impact on of panic attacks. Specific phobias, those are fears that interfere with your daily life. A normal fear doesn't interfere with daily life. Remember that for something to be a psychological disorder, it has to interfere with your functioning. And so when a fear of things such as dogs and fish, or high places, or spiders, or fear of bees, whatever, affects your ability to function, then it becomes a categorized phobia and a psychological disorder. Social anxiety disorders, also called social phobias, an intense fear of being humiliated or being embarrassed in social situations. Interestingly, Carly Simon, Barbra Streisand have dealt with social phobia. Appears to have a genetic component, also possibly involving neurotransmitters, so this could fall into the biological category. And it involves lots of vulnerabilities, such as genetic characteristics, maybe parenting styles, and so forth. Obsessive compulsive disorder. Normal checking behavior includes, the fact that you leave and you think maybe you left the coffee pot on and you have to check. That's not obsessive compulsive. Obsessive compulsive are these anxiety provoking thoughts that will not go away, or that you end up performing some repetitive ritualistic behavior. You have to go back and check to see if the door is locked 7, 8, 9, maybe you have to do it 10 times before you can leave the house. Important differentiation: obsessions are recurrent thoughts, compulsions are recurrent behaviors. So the difference there between thoughts and behaviors. And folks with OCD, they dwell on their doubts and repeat routines, sometimes hundreds of times a day. Most common, excessive checking, cleansing, and sometimes counting. Let's see. Move that out of the way. Oh, there we go. Come back. Oh, let's take a break and fix this slide. There we go. Anxiety disorders. There appears to be a genetic component to obsessive compulsive disorder. Brain imaging studies have suggested neurological links, possibly the frontal cortex or basal ganglia. They are very active in OCD. That numerous impulses reach the thalamus, which generate thoughts. Also, low neurotransmitter levels are possibly the result. There's the thalamus, frontal cortex, hippocampus, and so they think that potentially these areas are involved in the physical causes of OCD. OCD-related disorders include hoarding disorders, excoriation, where you pick at your skin, what they call trichotillomania, which means things like pulling out all your eyelashes. People do it. And body dysmorphic disorder, where people imagine flaws in their appearance, and that could potentially lead them to even have extreme cosmetic surgery. And I think we've seen examples of that. PTSD, post-traumatic stress disorder, it's been expanded by DSM-5 as we said, to include not only those who experience trauma, but who hear about it. Symptoms include flashbacks, avoiding emotional experiences or talking about your emotions, a reduced ability to feel emotions, feeling numb, excessive arousal, like an exaggerated startle response. Somebody slams a door and you freak out. Difficulty with memory and concentration, and impulsive behavior. And interestingly, PTSD symptoms can happen immediately after a trauma, or it can even be several years before the PTSD actually begins to occur in individuals. All right, mood disorders. This includes depressive disorders, where individuals have an unrelenting lack of pleasure in life. That's the definition of depression. These disorders are very common. Recent survey of individuals from age 13 and up found 30% reported a depressive episode or diagnosis in the past 12 months. Major depressive disorder involves a significant depressive episode and then characteristics such as being lethargic and hopeless for at least 2 weeks. So it has to go, this is not just having a bad day and being depressed. Major depressive disorder has to go on for at least 2 weeks to be identified. The symptoms are depressed mood for most of the day, loss of interest in items you used to enjoy, significant weight loss, or significant gain, decrease or interest in appetite, trouble sleeping, fatigue, feeling worthless or guilty, problems concentrating, recurrent thoughts of death and suicide, and no history of manic depressives. In other words, no euphoria that would be involved in a sort of a manic depression or a bipolar. That all has to go on for at least 2 weeks for it to be considered major depressive disorder. Biological factors that could play a role, some brain conditions, some depressed individuals have a lower level of brain activity in the prefrontal cortex. That's the area that generates actions, that allows you to be motivated, and also regions of the brain associated with reward seem to be affected. A depressed person's brain apparently doesn't seem to recognize rewards or to feel them. That could be a neurotransmitter problem, so a biological connection there. Psychological explanations of depression come from behavioral learning and cognitive theories. Remember we talked about learned helplessness, about the dogs who suffered the shock, and when they couldn't get away, they didn't even bother to try when they had the opportunity. That could also lead to depression. Martin Seligman proposed that learned helplessness is the reason people become depressed, because they can't control their stress and the things happening to them, and when they realize they can't control it, they stop trying, and that leads them to feel helplessness, which spirals into hopelessness, which causes depression. Other psychological factors, the way people think. Depressed people tend to ruminate over negative experiences, playing them over and over again. Actually sounds almost like an OCD type of thing, where they can't seem to get them out of their head. There's also the idea that depression may be linked to a pessimistic attributional style. You remember when we talked about attribution, where when something happens to you, you attribute it to either an internal factor, it was me, or an external factor, it was something else. But people with a pessimistic style, when bad things happen, they tend to attribute it to themselves. It's my fault that everything's bad, and they tend to believe these things are stable. Things are always going to be bad because I'm always going to be bad, and that leads into this depressive downward spiral. Sociocultural factors in depression, low socioeconomic status. People who are poor tend to also be affected by depression. Makes sense. Women twice as likely as men to develop depression. Also among single women who are heads of households, or married women with unsatisfying dead-end jobs. So you can see that, again, this helplessness, this being in a situation that you can't help, tends to be a connection or a cause of depression. Bipolar disorder is characterized by extreme mood swings. Now, this is different from depression, because in depression you're basically always down. In bipolar disorder, you have one or more episodes of what they call mania, which is an overexcited, unrealistically optimistic state. It's the flip side of depression. Now, these aren't necessarily happy. It's almost like these individuals are driven in this case. But that's what one of the main differences between depression and bipolar is. Bipolar involves extreme mood swings from one to the other. Emotion and mood disorders can lead to suicide. Thinking about suicide is not necessarily abnormal, that's very important, but attempting or completing the act is considered abnormal, and about 90% of the individuals who commit suicide are estimated to have a diagnosable mental disorder. That's important. And then the most common disorders that seem to be prevalent among individuals who commit suicide: depression and anxiety. Genetic factors seem to play a role in suicide. Suicides tend to run in families. Psychological factors that also seem to play a role in suicide: mental disorders, traumas such as sexual abuse, struggling with the stress of a psychological disorder can leave a person feeling hopeless. We get back into that whole sense of learned helplessness, where people feel that there's nothing they can do to get out of their situation. That seems to be connected to suicide attempts. Also, sociocultural factors: chronic economic hardship can be a factor in suicide. So individuals who are trapped in bad economic situations also seem to be affected. Good opportunity to take a minute to talk about what to do in a suicide situation. Say, for example, somebody you know or are somehow acquainted with makes a comment about suicide, or makes you think that they're talking about it. The way to deal with that is, one, ask direct, straightforward questions and be calm. Just say, are you thinking about hurting yourself? Being a good listener and being supportive, emphasizing that unbearable pain can be survived and isn't permanent. It's also very important to take a suicide threat very seriously. Ask questions about their feelings, their relationships, what their thoughts are about specific methods. If they mention specific things such as gun, pills, rope, or other means, that means that a plan has been developed, and that's very dangerous, and it's important to call for help and to stay with that person until help arrives. Also important to encourage that person to get professional help and help them to get it. If they're willing, take them to a hospital. Also important what not to do in a suicide situation. It's important not to ignore warning signs, not to refuse to talk if the person wants to talk. Don't overreact. Don't react with horror or disapproval or revulsion. Don't offer false reassurances like everything will be all right, because in their mind it won't. And don't make judgments saying, you should be thankful for this and that. Why are you feeling suicidal? Because it's not something they can control. And also, don't abandon the person after the crisis seems to have passed or after professional counseling has begun. It's something that takes time. All right, next, eating disorders. Moving next to eating disorders. Eating disorders, the one that's probably one of the two that are most common: anorexia nervosa, an eating disorder that involves the relentless pursuit of thinness through starvation, more common in girls and women than men and boys. Affects about between 0.5% and 3.7% of young women. Main characteristics: weight loss, more than 85% of what's considered normal, intense fear of gaining weight, and a distorted body image. Even when individuals are extremely thin, they don't think they're thin enough. And it makes you think that while it's called an eating disorder, clearly the lack of eating is caused by a lot of other issues: the body image, the fear, the phobia. The other eating disorder that is fairly commonly known, bulimia nervosa. Individuals in this case, they eat, but then they purge, whether through self-induced vomiting or using laxatives. Usually in this case, they're preoccupied with food, but also have a strong fear of being overweight. They become depressed and anxious. Binge eating disorder is characterized by recurrent episodes of consuming huge amounts of food. This is different from bulimia, because in binge eating disorder, the person doesn't try to purge or get rid of the food. They are typically overweight. They typically eat quickly, eat when they're not hungry, and eat until they're very uncomfortable. A lot of shame and embarrassment and so forth. And so those are the three most commonly known types of eating disorders: the anorexia nervosa, bulimia, and then binge eating. All right, getting into dissociative disorders. Dissociative because in this case there's a disconnection, I think, is a good way to think about that. They involve sudden loss of memory, being disconnected or changed, from your identity, sometimes under extreme stress or shock. Your conscious awareness becomes what they say refer to as disassociated, separated or split from previous memories or thoughts. People who develop dissociative disorders may be able to have difficulty putting together different aspects of consciousness. They might get the feeling that things are happening to someone else. You've heard of people who maybe are going through an extremely traumatic situation, maybe abuse, where their brain leaves their body and they say it was as if the abuse was happening to someone else and not me. They believe that's how people sometimes deal with extreme stress, by disassociating with what's happening. The types of dissociative disorders: dissociative amnesia, which is extreme memory loss that comes from psychological distress. People can remember everyday tasks, but they forget aspects of their own identity, maybe their autobiographical experiences. Maybe they'll unexpectedly leave or travel. Dissociative identity disorder, which used to be called multiple personality disorder, most dramatic and least common, and one of the more controversial disorders. These are individuals who appear to have two or more personalities, each one with its own memories, behaviors. One will dominate at a time and can actually take over the body. There appears to also be amnesia involved in that. All right, schizophrenia. We've heard about schizophrenia. Schizophrenia, and sometimes mistakenly we think of schizophrenia as split personality. It's not the same thing. Schizophrenia is a severe disorder characterized by a highly disordered thought process. They're referred to as psychotic because they're removed from reality. The world that they see is not the real world, and for them it can be very frightening and chaotic. Usually this happens in early adulthood, ages 18 to 25 for women. People with schizophrenia see things that are not there. They hear voices in their heads. Their logic is twisted. They may say things. It'd be emotionally inappropriate. May move in different ways, often socially withdrawn and isolated, as you can imagine. They're basically living in an internal mental hell. Their world is completely shattered from their own perspective inside their own heads. Symptoms include hallucinations, delusions, thought disorders or unusual thought processes. What's called referential thinking. It means you give personal meaning to random events. For example, I knew a situation where an individual was obsessed with a certain television news anchor, and this individual thought that everything she said on the news was specifically talking to him. That would be an example of referential thinking. A flat affect, meaning they don't display emotion. They have trouble maintaining attention, have trouble remembering things, they have trouble making decisions. Schizophrenia is thought to be at least partially genetic. There are structural brain abnormalities that they can see through an MRI that lead them to believe that there could be physical causes for schizophrenia, and there are also issues with neurotransmitters, that particularly dopamine, that seem to be linked to schizophrenia. One of the causes, the diathesis stress model. Diathesis stress means a physical vulnerability or predisposition to a particular disorder. This would be a situation. Where, for example, you might have the genetic predisposition. Let's say the genetic components that would cause you to be schizophrenic are in your brain, but you're not schizophrenic until you have an extremely stressful situation that triggers that biological predisposition, and the schizophrenia occurs. If you never had the stress, you might never become schizophrenic. So that's the idea of the diathesis stress model. People might inherit the predisposition to be schizophrenic, but they don't become schizophrenic until they get hit by extreme stress. Some sociocultural causes, because different cultures seem to have different rates of schizophrenia. developing non-industrialized nations appear to show indications of recovery over time for schizophrenia over those individuals in developing industrialized nations. Maybe that's because in the developing industrialized nations we have more stress that triggers these schizophrenic events. Okay, personality disorders, the last one on the list, a whole bunch of them. I won't go through each one of these. This comes from your textbook, Figure 1211, and that lists the different personality disorders and their characteristics: paranoia, schizoid, antisocial, borderline, histrionic, narcissistic, avoidant, dependent, obsessive compulsive, and so forth. Antisocial personality disorders, to take and pull that one out: failure to conform with social norms or obey laws, deceitfulness, being impulsive, irritable, reckless disregard for the safety of others, constant irresponsibility, inconsistent work, lack of remorse. Typically, this is the kind of person we'd call a jerk. But if you tie all this together, according to psychology, this person actually has a personality disorder. Borderline personality disorder is a pervasive pattern of instability in interpersonal relationships, self-image, emotions, and a lot of impulsive behavior. They're unstable moods, unstable sense of identity, self-harm, people who maybe engage in cutting, lots of mood swings, sensitive to how others treat them, emotional roller coaster. That's considered a borderline personality disorder. So those are two examples. The challenge, I think, and this particularly becomes something relevant when you talk about the expansion of the definition of mental illness in DSM-5, is the stigma. Because when you put a label on a person and say, you now have a psychological disorder, it kind of makes it, it makes it seem like it only happens to other people. You're now different from me because you have a disorder. Interestingly, more than 26% of Americans over 18 suffer from a diagnosable disorder, whether it's actually been diagnosed or not. It's 57 million people in the U.S. The stigma of being labeled with a psychological disorder can include prejudice, discrimination, damage to your physical health. Overcoming stigma really means resisting the thinking of people with psychological disorders. And remember, 57 million. We need to resist the thinking of them as limited. I've explained it as, when somebody has a disorder where they can't use their legs, they may well be limited in whether or not or how they can walk, but they're not limited as people. And I think the goal is to start thinking of people with a psychological disorder in the same way. They may have some limitations in how they can function, but they're not limited as people. And we'll close this lecture with just a reference. If you're interested, there is a website called Bring Change to Mind that actually has a pledge to help people learn how to avoid the stigma of mental illness, which is for people living with mental illness to remember that they're valuable, that they're responsible for their decisions, that they can educate, and then for everybody else. But the idea being that if you just because DSM-5 says or doesn't say you are or are not dealing with a mental issue, does not affect who you are as a person and your value and your ability to contribute. And there are a lot of things we can do to improve our health and our healthy attitudes. At this point, regarding your response question. So for your response question, is the stigma associated with psychological disorders a problem today? I mean, have we advanced far enough that being diagnosed as having a psychological disorder is not a big deal? Or does it potentially still affect our ability to function? Because the issue is, if being diagnosed with a psychological disorder has stigma attached to it, then people are going to be less likely to seek help, to seek a diagnosis, because they don't want to be labeled. So is labeling still a problem today? What do you think about that? Click reply, post a response. Next video lecture will be next weekend, the weekend after Thanksgiving, or the week after Thanksgiving. I'll have to look up that date. Anyway, there'll be one more video lecture that's going to cover psychological health, and then when we meet in class again on that next Friday, we'll have exam 4. You should already have the study sheet for exam 4. I'll go ahead and post that in Blackboard. Anyway, thank you for your attention. Have a great Thanksgiving.